Hello, and welcome to the Neurology Video Journal Club. I'm Tiffany Brown. I'm a vascular neurologist and neurohospitalist at Baylor Scott and White in Temple, Texas. And I'm joined today by Dr. Sharon Poisson.
Hi, thanks, Tiffany. I'm Sharon Poisson. I am also a vascular neurologist and neurohospitalist at the University of Colorado, and I'm the medical co-director of the Comprehensive Stroke Program here at University of Colorado.
And today we'll be discussing an article published in April 2023 titled Changing Trends in Demographics, Risk Factors, and Clinical Features of Patients with Infective Endocarditis-Related Stroke from 2005 to 2015. So infective endocarditis is an important topic. It's an important stroke etiology to consider when we're evaluating patients with stroke symptoms. Although it is an uncommon stroke etiology, it does require specific treatments with antimicrobial therapy and sometimes surgical management in order to make sure that we're reducing morbidity and preventing ongoing embolic events. Endocarditis also involves a high risk of hemorrhagic transformation and must be considered in stroke patients who are candidates for acute thrombolytic therapy, since, of course, infective endocarditis would be a contraindication for thrombolytics in the acute setting. There has been an increase in infective endocarditis-related strokes correlating with the increase in opioid use during the current opioid epidemic, which began around the 1990s. And the author's aim here with this study was to explore data regarding the clinical characteristics of patients affected by infective endocarditis-related stroke during recent years. Understanding the risk factors and demographics of patients affected by endocarditis-related stroke will help us to better identify these patients and provide them with the highest quality care in order to improve outcomes for this condition, which has a high mortality. The authors cite that up to 20 to 40% of patients with infective endocarditis will develop ischemic stroke. There are also other studies which have found that clinically silent cerebral emboli are quite common in patients with infective endocarditis. So this is an important topic that we have limited data for, considering how rare infective endocarditis is overall. The authors mention that infective endocarditis-related stroke often occurs within the first week of infection, and stroke symptoms are often the initial reason that patients seek medical care. The authors cite one paper from the Scandinavian Journal of Infectious Diseases, which is a retrospective review of all cases of infective endocarditis within one institution in France between 2000 and 2007. And here they found that of the total 34 patients, 26 presented initially with stroke before being diagnosed with infective endocarditis. They found that there was often a significant delay between diagnosis of stroke and diagnosis of infective endocarditis, with a mean delay of about 8 days. And not surprisingly, this delay in diagnosing infective endocarditis was longer in patients who had negative blood cultures. This table is from this paper, and it shows the delay between stroke diagnosis and infective endocarditis diagnosis, with the negative numbers indicating cases where stroke was diagnosed prior to infective endocarditis. You can see that most of their patients were diagnosed with stroke prior to the infective endocarditis, and of those patients, the delay to endocarditis diagnosis ranged from 0 days to 40 days. It's also worth noting that the study of 7 years of data had a very small cohort of just 34 endocarditis patients, which shows how difficult it is to study this disease due to it being uncommon.
So thanks, Tiffany, for the introduction. I'm going to talk a little bit about this paper and the methods of this paper in trying to address the question of infective endocarditis-related stroke. So this study was done within the Greater Cincinnati Northern Kentucky Stroke Study, which is a large population-based epidemiologic study that's been collecting data regarding stroke beginning as early as the early 1990s. So has actually provided quite a bit of data about stroke within a metropolitan region in the United States. And something that's really important about the study is that the demographics of the region are really pretty representative of the United States population. Most specifically, the age of the population is similar to the overall age of the US, as well as it's a biracial community, and the percent of Black residents is similar to the percentage within the US, and socioeconomic indicators are similar to the US population. So as part of this study, every 5 years, they identify all residents of this greater Cincinnati, Northern Kentucky region who are hospitalized within acute care hospitals in the region with ischemic and hemorrhagic strokes. They also review autopsy data and deaths to identify patients with stroke of all types. For this specific study, they used the data regarding people hospitalized with stroke in 2005, 2010, and 2015. So those were the 3 time periods they used to do this study. They identified all of the stroke patients within those years, and then identified infective endocarditis-related strokes using ICD-9 and 10 codes. And then those patients with possible infective endocarditis-related stroke all were adjudicated by study physicians using the modified Duke criteria for possible or definite infective endocarditis-related stroke. And so this is just a reminder of the modified Duke criteria for endocarditis diagnosis. I needed a reminder for myself, and I thought others might appreciate looking at them again. So to make a diagnosis of definite infective endocarditis, you can see any of the 2 pathologic criteria could be met, and that would give you a definite infective endocarditis diagnosis. Other ways that you can give a definite infective endocarditis diagnosis is by either getting all or both of the 2 major clinical criteria, or 1 major and 3 of the minor criteria, or all 5 of the minor criteria. And any of those would qualify as a definite diagnosis. For a possible diagnosis of infective endocarditis, either 1 major and 1 minor criteria or 3 minor criteria can be met. So as part of the Greater Cincinnati, Northern Kentucky Stroke Study, there is electronic data collected on all strokes. That data was used for this analysis. And then beyond that, for the individuals who had identified infective endocarditis-related stroke, they did further chart review and abstraction of data. This was a relatively small number of patients, which you'll hear when we talk about the results. And so it was possible to go through and abstract further data, whereas it is much harder to do that for the overall stroke population. This means that there is some data that we cannot compare between the endocarditis-related stroke and the overall stroke population. And I think the most important one to point out, and again, we'll talk about it a little bit more later, is that they were able to abstract active IV drug use from the infective endocarditis-related stroke patients. They were not able to do that from the overall stroke population. So it limits the comparison of IV drug use between patients with and without endocarditis. They used the medical records to abstract neurologic outcomes, and also used the CDC National Death Index in order to determine mortality. And then the main analyses they did in terms of statistics, and Tiffany will go into this in a few minutes, but first, they compared infective endocarditis-related stroke to non-infective endocarditis-related stroke in terms of their demographics, risk factors, presentation, and outcomes across this 10-year time period. And then also used US Census data to calculate overall stroke rate as well as endocarditis-related stroke rate over time, adjusting those for race, age, and sex. They weren't able to do a statistical test on the rate change among infective endocarditis-related stroke because of the small number of cases. They also evaluated the trends in how infective endocarditis-related stroke presented across the time period, and then compared the demographics, clinical characteristics, and presentation among patients with endocarditis-related stroke who were active IV drug users versus non-IV drug users. I'm going to turn it back over to you, Tiffany, and you can tell us a little bit about the results.
So this table from the paper shows trends and characteristics of infective endocarditis-related stroke and the entire stroke patient population from this study. The authors studied a total of 54 cases of infective endocarditis-related stroke and over 8,000 cases of stroke from other etiologies. There were fewer infective endocarditis-related stroke cases associated with hypertension over time, from 91.7% in 2005 to 36% in 2015, but significantly more IV drug use in this group, going from 8% in 2005 to 44% in 2015. In the non-infective endocarditis stroke patients, there was a trend towards higher prevalence of hypertension over time, an increase in Black individuals and in male individuals, as well as higher prevalence of diabetes, atrial fibrillation, malignancy, and perioperative stroke. There were non-statistically significant trends in the endocarditis stroke group for individuals of a younger age, more white individuals, and less prevalence of traditional vascular risk factors. So this table here shows the trends of clinical features of patients with infective endocarditis-related stroke. And about 44% of these patients presented within 6 hours of their last known normal, but only one patient received TPA, perhaps because of clinical suspicion of sepsis or endocarditis, or perhaps because these patients had nonspecific neurologic symptoms rather than clear focal neurologic symptoms to warrant the IV thrombolytics like TPA. The one patient that did receive TPA, unfortunately, had a fatal symptomatic hemorrhagic transformation. And most of these patients, as expected, had ischemic stroke, while about 14% had intraparenchymal hemorrhage and about 3% had subarachnoid hemorrhage. Hemorrhagic transformation occurred in about 22% of all infarcts in this group, and about half of those were symptomatic hemorrhagic transformations. And clinical signs of sepsis were present in only about 27%, less than a third of the endocarditis stroke patients. And it seems that most of these patients had a somewhat insidious presentation of their infective endocarditis, with only about 15% presenting with fever, and the group overall presented with just mild leukocytosis. Neurologic decline was quite common in this group, occurring in about 40% of the endocarditis patients across the study period. The authors reported in a separate table that vascular imaging was performed in about half of the endocarditis stroke cases. And I was surprised that only half of the patients had vascular imaging, because in my experience, we tend to get vascular imaging in all of our stroke patients. And about half of the group that got vascular imaging, of those, about 28% revealed mycotic aneurysms. And this was actually more than I expected, since in my own practice, I have rarely found patients with infective endocarditis-related strokes to have mycotic aneurysms. But Sharon, what's been your experience with that?
I agree with you on both points. I think, first of all, I was surprised at the low number of patients who had vascular imaging, and then the high number of those who had mycotic aneurysms. I do think it's important to take into account the time window in which this study was done, because we're speaking from a 2023 perspective, where we have very rapidly available CT angiogram at almost any stroke center out there, and it's used acutely for most stroke patients. This study occurred between 2005 and 2015. I suspect there was kind of an increase in the use of CTA over that time, but what the availability of it was is not as clear. And that might account for the lower number than we would expect who got CTAs. It also makes me wonder if, because we weren't using CTAs on all of the patients in those earlier time windows, if what we're seeing is that the CTAs were being done on patients in which there was a pretty high suspicion of a mycotic aneurysm. So patients who presented with hemorrhage or had some other finding that they felt made it very likely that they were going to have mycotic aneurysm. So I wonder if that helps to explain at least some of that. But I agree with you. My experience has not been that a quarter of patients who we do CTA on have mycotic aneurysms.
Thanks for your input. I think those are all excellent points too. This table shows the trends in rates and outcome of infective endocarditis-related stroke over the time of the study. The rates of infective endocarditis-related stroke did increase over time from 1.31 per 100,000 in 2005 to 2.41 per 100,000 in 2015, which is nearly double the rate of infective endocarditis-related stroke over 10 years. And this could certainly be in part due to the effects of the opioid epidemic, but it seems like quite a big increase for such a rare disease. And I did wonder if maybe the increase in endocarditis-related stroke is in part due to improved stroke diagnostic accuracy over this time frame and improvement in imaging techniques. But the stroke rate in the non-endocarditis patients remained relatively stable over this time, which is also included here in this table. And Sharon, do you have any other thoughts on what else may be contributing to the increase in endocarditis-related stroke rates here?
Yeah, I think it's not totally clear. I mean, the authors of this paper suggest that the opioid epidemic may be part of that. We can talk a little bit more about that during the further discussion. I think you're right that the increase in imaging over time, probably increased use of MRI over this time period, as well as increased quality of MRI images, may account for some of it. That would probably apply to both the non-infective endocarditis patients as well as infective endocarditis, but you could imagine a scenario where you have a patient who has now been diagnosed with infective endocarditis, and even if they didn't have specific stroke symptoms, they may get an MRI to evaluate for any infarcts, and you might find small non-clinically significant infarcts, and those patients then get a diagnosis of stroke. If you have a healthy patient, if they don't have the clinical symptoms of stroke, you wouldn't do the MRI. So I think that potentially improved and increased brain imaging is a possible contributor to the change. I wouldn't expect it to be such a big change just related to that. I think other things to think about is, as we've gotten more skilled at doing different cardiac surgeries, I wonder if cardiac implants, increased cardiac valve replacements and things like that may also, over this 10-year time period, have accounted for some of the increase in endocarditis that we see.
Thanks for your input. I think, again, those are really good points. And unfortunately, functional outcome and mortality rates remained poor over this time period, despite advances in stroke management. And we do see a statistically significant improvement in 90-day mortality seen in the non-infective endocarditis-related stroke group over the same time frame, probably at least in part due to improvements in stroke care. But I think this also shows us how limited we are with managing and preventing endocarditis-related ischemic strokes, since we often have to avoid antithrombotic therapy in these patients due to their high risk of hemorrhage. And it also shows that this entity has a high risk of mortality and poor outcomes. So this table is specifically looking at the characteristics of patients with IV drug use and endocarditis-related strokes compared to the patients with no IV drug use and endocarditis. The patients with active IV drug use were more likely to be of a younger age, male, and less frequently had atrial fibrillation and end-stage renal disease. Urine drug testing was positive for opioids in over 60%, of the patients with active IV drug use, while none of the patients without IV drug use tested positive for opioids. And I think this may speak to the opioid epidemic contributing to patient use of IV drugs and subsequently the prevalence of endocarditis-related stroke. Patients with IV drug use were significantly more likely to be septic and to have fever at presentation compared to the patients without IV drug use. Although the trend for difference in time to presentation between the two groups did not reach statistical significance, half of the patients with IV drug use presented over 24 hours after their last known well time, while more than half the patients without IV drug use presented within 6 hours of their last known well time. So perhaps patients with IV drug use tend to present longer after their last known well due to difficulty in identifying stroke symptoms in this group, or perhaps these patients tend to lack social support for transportation to the hospital and activating EMS. The authors also mention that perhaps patients with IV drug use may be more reluctant to seek medical care. The patients with IV drug use had a statistically significant trend for a better outcome at 30 days compared to the non-IV drug use group, as defined in this paper by the median modified Rankin scale for each of these groups at 30 days. And there was a higher rate of death by 30 days and by 90 days in the non-IV drug use group compared to the patients with IV drug use, although this trend did not reach statistical significance.
Great, thanks. So I was going to just kind of briefly summarize the really 4 main take-home points that I got from reading this study. And then maybe we can dive in a little bit deeper, Tiffany, and talk about those take-home points and have some conversation about it. The 4 take-home points that I found, I think number 1, we saw that the demographics of infective endocarditis-related stroke have shifted over the time period from 2005 to 2015, with the infective endocarditis-related stroke patients being younger, more likely to have IV drug use, and less likely to have hypertension. So that is kind of take-home point number 1. In addition, we saw a trend, at least, toward an increasing incidence of infective endocarditis-related stroke over the time period. This wasn't statistically tested because of the small number of cases, but as Tiffany pointed out, I think it's certainly a trend that looks like it is an important one. Third, the majority of individuals with infective endocarditis-related stroke came in with stroke symptoms, and very few had infectious symptoms prior to stroke. This is, while not the first time it's been shown, I think it remains surprising and a little bit concerning from the standpoint of a stroke neurologist. And then fourth, I think, functional outcomes after infective endocarditis-related stroke are poor. And that's, again, been shown in the past, and I think reiterated here, although perhaps there is kind of a dichotomy in outcomes between patients with active IV drug use versus non-IV drug use related endocarditis. Before we really dig into those, I think it's always important to think about the limitations of the study. This is a great study. We've gotten a lot of great data out of the Greater Cincinnati Northern Kentucky Stroke Study, and I think it's an important population to be studying. And as Tiffany, as you mentioned in the introduction, it is hard to study infective endocarditis-related stroke because it is not that common. And so in that prior study you looked at, there were maybe 34 patients, and in this study we have 54 patients, which is better, but still a relatively small number. So I think actually a big strength of this study is just that it is large, and they're able to accurately identify stroke overall as well as infective endocarditis-related stroke. The biggest limitation, though, is really just the nature of the study. So number 1, there's a small number of infective endocarditis-related stroke patients, which we already talked about. It's a retrospective study, and so that limits what we can do in terms of collecting data on details of presentation. And then I think the other limitation, given that a big interest of this study was looking at the role of IV drug use in causing infective endocarditis-related stroke, is that we don't know the active IV drug use status of the patients who had stroke overall. And so it's a little bit hard to make that connection between whether the increase in IV drug use truly was something that we saw just in the infective endocarditis-related stroke cases versus were we just seeing the exact same trend that we would have seen in the overall population during that time period. I think it's well understood why they weren't able to collect that, but is a limitation. So getting back to the main points, I think in terms of the demographics shifting, so just again to kind of summarize, there was a non-significant shift towards younger ages in the infective endocarditis-related stroke patients, while in the overall stroke population, the age remained stable. And then patients with endocarditis-related stroke had a decline in hypertension and then a non-significant trend towards less diabetes, whereas patients with non-endocarditis-related stroke had increasing vascular risk factors, so more hypertension, diabetes, AFib, which I think is what we expect in the overall stroke population, is that we're seeing more and more vascular risk factors in the population. So in my interpretation of this, I mean, I think it certainly could fit in with the author's kind of hypothesis that infective endocarditis-related stroke is becoming more associated with IV drug use over time. And that may explain why, you know, if you have a population of patients with active IV drug use, those are more likely to be younger patients, more likely to have fewer comorbidities, and so may explain that driver of changing demographics of that population. I'd expect if this was related to us putting in more cardiac valves or LVADs and invasive procedures that you'd actually see the opposite. So we'd be seeing an increase in the age and an increase certainly in vascular risk factors in that population. Any thoughts on that, Tiffany?
No, I think that makes a lot of sense. I do think we, over this time frame, probably have utilized more cardiac devices, more implantable devices, and but you make a good point about how we would probably expect to see these patients look a little sicker as far as medical comorbidities and more frequent medical comorbidities if that were the case.
Yeah, I agree. In terms of the trend in stroke rate or in infective endocarditis related stroke rate, as you mentioned, Tiffany, there was almost a doubling of the incidence over the 10-year time period, which hard to say if that is a significant trend, but it is concerning to look at in terms of the numbers. And if you look at the overall population, the overall stroke rate was stable over that time period. So it seems to be divergent from the overall stroke rate. And again, I think that the IV drug use hypothesis, I think, fits in with this. There's they gave some background in the paper about the opioid epidemic in specifically in Ohio, and the timing of this study really does kind of coincide with most of the opioid epidemic in Ohio. So Ohio had, as of 2018, Ohio had the 4th highest rate of opioid-related deaths in the US. And then in terms of timing, the rapid increase in these deaths started around 2008, so shortly after this study period started, and peaked in 2016, which is just after that last sample from this study. And it's interesting to note that the southwest portion of Ohio is where the highest rate of heroin-related deaths have been seen within Ohio, and that region just overlaps nicely with this greater Cincinnati, Northern Kentucky region. So again, I think all of this could support the hypothesis that the opioid epidemic and IV drug use is really the main driver of what we're seeing in the infective endocarditis-related stroke. My third take-home point, and I alluded to this before, is probably the most concerning for me, just as a practicing vascular neurologist. So the vast majority of these patients, I think almost 75% presented first with stroke symptoms, had no diagnosis of infective endocarditis, had no infectious symptoms first. So only 20% or so had known infective endocarditis prior to the stroke, and less than half had fever, sepsis, or known infection at the time of presentation. So all of that together suggests that clinically, based on history, it's really hard to diagnose infective endocarditis acutely when somebody comes into the ER. And then this study found like a very mild elevation of white blood count, which is not something that would typically trigger me to think, oh, this patient has endocarditis. And there are some other prior studies that have looked at other biomarkers like CRP and procalcitonin and D-dimer. And overall, the sense I get is that there are no great biomarkers to tell us if somebody has endocarditis. So, you know, as someone who is always trying to push faster identification of patients who are candidates for thrombolytic therapy, that's certainly gives me concern, because we think that the hemorrhage rate is going to be much higher in these patients if we give them thrombolytics. And there, one patient who had a hemorrhage would line up with that, but kind of the take home is that there isn't a great way to identify endocarditis. I actually wondered if adding in exam findings, just general physical exam findings, might change that sort of sensitivity for the diagnosis. I think that's a really hard thing to study, certainly hard in a retrospective study to determine what parts of the physical exam were always done, and were people looking for a new murmur or petechial hemorrhages or Janeway lesions, Osler's nodes, you know, kind of these classic endocarditis findings. But it would be interesting to know if that adds to the sensitivity, and if so, are we doing those things on physical exam, and how do we sort of spread the word about making sure we're thinking about this prior to giving thrombolytics? What are your thoughts?
Yeah, I agree. It's unsettling when we're thinking about TPA and tenecteplase place decisions, because of course we want to avoid giving thrombolytics to patients with endocarditis, and the fact that they have such an insidious presentation makes that difficult. And I do think in my practice, this is going to push me to make sure I'm doing a careful physical exam outside of the neurologic exam, looking for things like Janeway lesions, Osler's nodes, even though, as you mentioned, they're not very sensitive either. But at least if we could catch something that would give us a red flag to maybe consider endocarditis in that specific patient when we're weighing the risks and benefits of thrombolytic decisions. And I certainly think that future studies could focus on how can we accurately identify these patients in the acute setting, the patients that are at highest risk of having endocarditis, so that we can hopefully avoid giving thrombolytics to those patients, while at the same time not giving thrombolytics to patients who are good candidates. And also being able to identify them earlier would help us expedite proper care with antibiotics for these patients with endocarditis.
Yeah, I think one thing this study does is bring up a lot of questions that I have about other things that we ideally could study to help us to make sure we're treating these patients well. And then the last take-home point that I had talked about before is that the functional outcomes after infective endocarditis-related stroke. About a third of them had died by 30 days. post-stroke, and almost half had died by 3 months. Those outcomes were better in the IV drug use portion of the population. And so maybe that again kind of reflects the fewer comorbidities and younger, healthier kind of population that falls into that category. And it fits in with prior studies that have shown that similarly, overall outcomes are poor after infective endocarditis-related stroke, and that short-term outcomes are better in the IV drug use population, although longer-term outcomes in the IV drug use population are still poor. And that might have to do with relapse from for the IV drug use and other non-stroke causes of morbidity and mortality. What do you think in terms of, so we've talked a little bit about other clinical questions that might, that this study brings up that we might want to look at in the future to try to help us treat these patients. Any others that we haven't talked about yet, Tiffany, that you've thought of?
So I do think, even though this study was more recent than other large population studies of endocarditis-related stroke, this study is one of the more recent ones. It still only went up to 2015, so we're almost 10 years past the end of this study. So I think studying modern populations and seeing if there's been a change compared to this paper's data would be really interesting.
Yeah, I agree. I think along those lines, something that popped into my head as reading the paper is, they mentioned that only one patient had endovascular therapy. And it's not clear to me exactly why it was, again, such a small number. I mean, they presented kind of late, not clear how many of these patients had large vessel occlusions, also not clear what the risk of endovascular therapy is in this population. The study was done, most of this study happened prior to us having good data about endovascular therapy and when it's beneficial. And as you know, we've had more and more kind of data and indications for endovascular therapy over really the last, especially the last 10 years or so. And so I think that's another curious question. I think it's the expert consensus, at least, is that thrombolytics are not safe in this population. But I wonder, is endovascular therapy something that we can offer to these patients to help with these poor outcomes that they have? And if so, I think the other question is how many of them actually present with large vessel occlusions versus more small vessel strokes, and how many would be candidates for that treatment. It feels challenging to offer much in the way of treatment that will help outcomes outside of antibiotics, obviously. So identifying endocarditis is important. But beyond that, from a stroke perspective, we really don't have a good way of helping to intervene. So it would be great if we were able to determine whether endovascular therapy is a way to help with outcomes. Any other last minute thoughts you have, Tiffany?
I think this was a really great paper. It shed a lot of light on endocarditis-related strokes, and it definitely gave me a lot to think about when I'm approaching these patients in the clinical setting.
Great. Well, this has been a fun discussion. I think it's a great paper and fun to dive into it with you guys. Thanks to everybody for watching the Neurology Video Journal Club, and I think we'll sign off there.